Ever wrestled with a decision where, the lines between right and wrong just feel blurry? I think
Yeah.
we all have.
Oh, absolutely. It's part of being human.
But imagine trying to navigate that gray area when the stakes are incredibly high.
Yeah.
Like, in the really intricate world of providing substance abuse treatment for people who are also living with HIV/AIDS.
Exactly. That's the complex and really profoundly important terrain we're exploring today. We're digging into a U.S. government resource that looks at the practical, ethical side of things in this field.
Right.
And this isn't just like abstract theory. It highlights the very real, sometimes agonizing choices that professionals face every day in this work.
So our mission for this deep dive is pretty clear. We want to unpack the core ethical principles and the unique challenges that pop up right at that intersection of substance abuse for HIV/AIDS treatment.
Yeah, trying to get some insight into the incredibly tough calls these professionals have to make, understanding the framework they use.
And it's important to remember, like you said, these ethical issues, they're not just happening on one level, are they?
Not at all. They're right there in the immediate back and forth between a client and a provider. That's the personal side.
Hmm.
But they also influence the bigger picture societal views, the policies that actually govern care. That's the sort of systemic dimension.
Okay, let's unpack this a bit. When we talk about ethics here, what are we really getting at? Sometimes it feels like this big philosophical thing, maybe a bit detached from the daily grind of helping people.
Yeah, it can definitely involve philosophical debate, but at its core, ethics is really a practical tool. It's a framework for looking critically at the moral issues that come up in our everyday choices.
Okay.
It gives you an intellectual way to approach the principles guiding our actions. And that becomes especially crucial in, well, emotionally charged fields like substance abuse treatment. The National Association of Social Workers, for instance, they talk about ethics as that philosophical basis for really evaluating actions in all sorts of life situations.
You mentioned emotionally charged. Why is that so key when we're talking ethics here?
Because the history, unfortunately, of how society sees people struggling with addiction is just loaded with strong emotions, misconceptions, deep-seated biases.
Right.
And these views, they've historically had a real, tangible, negative impact on the care people received. Our source points out someone might face negative assumptions just walking into a healthcare setting because they have that label drug abuser.
Wow.
So because of that intense atmosphere, it's just essential that providers have objective tools to help them navigate these ethical tightropes and maybe just as importantly to understand their own reactions, their own potential blind spots.
And then you throw HIV/AIDS into the mix.
Yeah.
How does that add another layer of ethical considerations onto what's already a really challenging situation?
Well, HIV/AIDS brings its own unique set of ethical concerns. The virus can be transmitted through activities that unfortunately stir up a lot of personal feelings and often pretty harsh judgment from the public, and sometimes from healthcare and social service providers too, frankly. The ways it's transmitted, sexual activity, sharing drug equipment, they just carry their own heavy societal baggage.
So it's like this extra layer of stigma of judgment.
Precisely. And advocates for people living with HIV have fought incredibly hard for things like confidentiality, pushing back against, blanket mandatory reporting and making sure people can actually get the care they need.
Makes sense.
Given the existing stigma around substance use and historically around being identified as homosexual, plus all the fear and misunderstanding about HIV itself. Well, there's been a really strong push to prevent discrimination against people facing these dual challenges and really against anyone with HIV. And that's led to safeguards, trying to protect people from discrimination in really critical areas, healthcare, jobs, housing.
So we're seeing these ethical things playing out both individually, like in the room with the client and provider, but also on this much bigger stage, shaping policy, shaping how society thinks. The resource talks about micro and macro levels.
Right.
Can you give us a concrete example of how those two connect?
Yeah, absolutely. Syringe exchange programs, or SEPs, are a really clear example of this tension.
Okay.
So scientifically, the U.S. Department of Health and Human Services looked at a whole bunch of research. And way back in 1998, they basically said, yes, SEPs can be an effective part of a bigger strategy to prevent HIV transmission.
So a public health benefit.
Potentially, yes. For society as a whole, reducing the spread of a serious virus. But then you get the ethical questions, right?
The other side of the coin.
Exactly. The debate often boils down to, does providing clean needles somehow, condone or even encourage illegal drug use? And that ethical concern, that specific worry, has historically led to federal funding restrictions for SEPs. So you've got science suggesting a benefit clashing with these ethical worries about enabling drug use, which then directly translates into policy, into funding decisions.
Ah,
And so alcohol and drug counselors, they're often stuck in the middle. They're dealing with their individual clients' dilemmas, but also these huge macro policy issues that directly affect whether they can even provide effective care. They might end up advocating for policy changes or just trying to work within the existing rules.
it sounds like these professionals are constantly doing this balancing act, their own personal beliefs, the official ethical codes of their profession, and the rules of where they work. How do they even start to navigate that? It seems incredibly complex.
It is a crucial balancing act, and yeah, often really challenging. Counselors have to figure out how to square what they personally think is right with what's considered ethically sound by their professional codes, like the NSW Code of Ethics for Social Workers, and with the specific standards and policies of their own agency.
Hmm. So conflicts can definitely arise.
Oh, for sure. There can be times when someone's personal beliefs just don't quite line up with the professional guidelines, or maybe even with their agency's rules. In those cases, you're constantly weighing, personal feelings against these established professional standards and workplace policies. It takes careful thought.
And what about when a client's behavior clashes with the clinician's own values?
Yeah.
The resource mentions it goes beyond the really obvious stuff like threats of harm. There are more subtle, everyday things.
Absolutely. I mean, everyone knows you have to step in if there's imminent danger, suicide threats, homicide threats, that's clear. But a lot of the ethical stuff that comes up daily is much, much fuzzier.
Like what, for example?
Well, it could be things that seem small, but they add up. Like, did the client really understand what they were signing with that release of information form? Or did they just feel pressured? Or did the clinician genuinely consider the client's cultural background when making the treatment plan? Was it truly culturally sensitive care? Or maybe was some private info shared with another agency without following the proper consent steps? These are the kinds of everyday ethical checks that need constant attention because they really impact care and professional reputation.
Okay, so to help sort through all this complexity, the resource lays out 5 basic ethical principles as a kind of foundation. Let's dig into those. The first one is justice. What does that really mean in this specific work?
Right, justice. At its heart, it's about impartiality and equality. It means a clinician should try their best to treat all clients fairly, making sure everyone gets the services they're entitled to.
Okay.
And that applies not just to the individual client sitting in front of them, but also on that bigger societal level, issues like equal access to resources, fair distribution of services.
But it also brings up a really human point, doesn't it? How possible is it, really, to treat everyone exactly the same? It asks if clinicians have favorite clients or ones they might instinctively pull back from.
Yeah, and that's such a crucial acknowledgement of, well, human nature. It's just not realistic to pretend personal preferences or biases don't exist. The real key is self-awareness.
Okay.
Being aware of when and how those feelings might be affecting your ability to practice justly. Making sure no client is unfairly disadvantaged or denied treatment that others get. And this involves understanding something called countertransference.
Intertransference.
Yeah, it's basically the clinician's own emotional reactions, conscious and unconscious, to what the client brings into the room. Recognizing those feelings is vital because they can subtly influence how you see and interact with the client.
So what do you do about it?
Well, you need to recognize it and, crucially, know when to seek supervision, talk it through with a supervisor to make sure your personal feelings aren't blocking you from working effectively with all your clients.
And it sounds like the agencies, the organizations themselves, have a big role in promoting justice, too.
Oh, absolutely. Agencies can put safeguards in place. Things like standardized intake procedures, making sure every new client gets assessed within a certain time frame.
Right.
Or an agency could work really hard to define its service criteria clearly, basing decisions on objective information, not just a staff member's gut feeling. Policies like that help create a baseline of fairness no matter how an individual worker might feel.
Okay, the second principle, autonomy. That seems pretty straightforward, respecting a client's right to make their own choices.
Yeah.
But how does that work practically when you're dealing with substance use, maybe HIV-related cognitive issues, things that could affect their ability to decide?
Right, autonomy. It definitely emphasizes respecting that individual right to self-determination, making decisions about your own life, as long as it doesn't hurt others. It's about honoring their inherent worth, promoting self-governance. But Exactly. In the context of working with people who have HIV and are struggling with substance use, the counselor has this really critical job of assessing if the client is actually competent to make informed decisions. Do they have the information they need? Can they process it to make a truly autonomous choice?
Competence sounds like a really tricky area here.
It absolutely is, and often one of the most ethically challenging parts of the job. People with HIV/AIDS can experience all sorts of things: neuropsychiatric issues, metabolic problems, nutritional deficiencies, psychological conditions that can genuinely affect their judgment.
And the substance use itself, too.
Exactly. Active use, withdrawal, long-term effects,
Right.
they can all impair cognitive function, decision-making capacity. So if someone is deemed incompetent, just allowing complete autonomy could actually lead to harm.
But figuring out if someone is truly incompetent sounds complicated.
Oh, it is. It's not always clear-cut, and the formal process can be complex and take time.
The resource also mentions that a client's competence can shift. It can fluctuate.
Mm-hmm.
How do providers handle that uncertainty?
That's a really key point. Competency isn't always static, right? Someone might seem unable to make decisions one day and then be perfectly lucid the next.
So you can't judge based on one interaction.
Exactly. You have to look beyond a single snapshot. Consider how long any judgment-impairing behavior has been going on, how severe it is. Talk to others in their support network if possible.
Get a broader picture.
Yes. Consulting with doctors, psychiatrists, gathering info from family or friends, understanding their usual baseline, all that helps clarify if there's a real change in mental state. And, the resource reminds us, someone might have legal documents already in place, like a living will or a healthcare proxy.
Okay.
Those become really important if the person currently seems unable to manage their own care. And in really serious, persistent cases, seeking a court-appointed guardian might unfortunately become necessary to protect them.
And even when a client is competent, there's still this issue of making sure they have all the info they need to make that autonomous choice, especially if the clinician has a different view.
Precisely. This is where the clinician's own beliefs can really sneak in. Imagine a clinician strongly believes in one specific HIV treatment. The client's doctors are recommending it, but the client wants to explore alternative therapies.
Correct.
Can that clinician truly set aside their own conviction and give an objective rundown of all the options without subtly steering the client towards their preferred choice? It can be incredibly hard not to emphasize certain information over other information.
So what's the advice there?
The resource suggests, at minimum, clinicians should just be open about their own perspective, acknowledge it to the client. That transparency can actually build trust.
Really?
Yeah, the client understands where the clinician is coming from, but still feels empowered to ask questions, explore everything. They might even be more open to the clinician's preferred approach later if they didn't feel pushed initially.
Interesting. Okay, third principle, beneficence. The responsibility to actively do good, improve well-being. Sounds simple enough, but I gather it's not always clear-cut.
You're absolutely right. Beneficence, do good, sounds like a straightforward command, doesn't it? But what actually constitutes good can be really subjective.
How so?
Well, what a substance abuse counselor thinks is doing good might be seen very differently by the client. The counselor has to constantly ask, whose goals are we prioritizing here? Mine, the agency's, or most importantly, the client's own stated needs and desires.
And culture plays a role.
Huge role. The cultural background of the counselor, the agency, might be miles apart from the client's values. That shapes perceptions of what's actually helpful. Things like family roles, traditional healing practices, personal lifestyle choices.
Yeah.
They all influence what a client sees as good treatment, and that varies wildly.
And the resource links this to the idea of paternalism. Can you explain that in this context?
Yeah, paternalism is basically when a clinician, thinking they know best, makes decisions for the client or limits their choices without fully bringing them into the process. The resource gives an example. A clinician might tell a doctor, oh, this client isn't a good candidate for that complex HIV combo therapy because they're still using drugs. They're assuming the client won't stick to the regimen.
Okay.
But hold on. Did the clinician actually have a real in-depth talk with the client about it? Did the client get a chance to express their understanding, their worries, their commitment? The clinician has to actively consider the client's view, their cultural context, before deciding what doing good really means for them, rather than just imposing assumptions or standard protocols.
Right. Makes sense. Moving to number 4, non-maleficence. Essentially, do no harm. Seems even more direct, but again, the resource suggests harm can be subtle here.
It does. Obviously, non-maleficence means avoiding blatant harm like exploitation, sexual or financial, that's a given.
Sure.
But harm can happen in quieter ways, especially with this complex group dealing with both HIV and substance use. The resource uses the whole debate around abstinence-based versus harm reduction treatment as an example.
How does that relate to do no harm?
Well, interpretations differ, often based on really strong personal beliefs. Abstinence folks might argue harm reduction actually causes harm by enabling continued drug use, preventing recovery. Harm reduction folks might argue that abstinence-only models cause harm by lacking compassion, failing to meet immediate needs, maybe pushing people away from eventual recovery. See the conflict. Both sides believe they're preventing harm based on their view.
Yeah, I do. And it also gives a more micro-level example within the clinician-client relationship itself.
Yes, it talks about terminating or transferring clients. It acknowledges the reality of burnout in both HIV/AIDS and substance abuse fields. It's tough work.
For sure.
So when a clinician gets overloaded, emotionally drained, maybe their flexibility shrinks. A client has a minor slip-up, maybe they're late a few times, and they get terminated or transferred. Not necessarily because of the infraction itself, but maybe because they were the third person that day and the clinician just hit their limit. Yeah, and that seemingly routine action can really harm the client. It can damage their ability to trust future therapists, hurt their self-worth, especially if the agency rules about termination aren't clear or aren't applied consistently. The resource warns against clinicians acting like parents here and stresses having clear, consistently followed rules for transfers and terminations to avoid causing this kind of harm.
Okay. And the last of the 5 principles?
Yeah.
Fidelity. Telling the truth, keeping promises. Sounds absolutely basic for any trusting relationship, especially therapy.
It is totally fundamental. Fidelity is the bedrock of trust. When a counselor agrees to work with someone, there's an implicit promise, right? A promise to work diligently on their concerns, to treat shared information honestly and respectfully. Getting informed consent, signing forms reinforces that promise. What you tell me stays confidential with these specific exceptions. And the client also agrees to follow agency rules.
But the resource points out a potential pitfall here.
Yeah, it mentions that common practice of rushing through the consent paperwork at the end of the first session, trying to get it all done. But that can actually undermine fidelity right from the get-go if the client doesn't really absorb what they're agreeing to.
So, being totally upfront about the limits of confidentiality is key for fidelity.
Absolutely crucial. A clinician has to be crystal clear from the start about when that promise of confidentiality might need to be broken.
Like,
Immediate risk of harm, suicide, homicide threats, or situations involving child abuse or neglect. And also, if certain agency rules are broken repeatedly, the relationship might have to end. Communicating those limits up front avoids misunderstandings or feelings of betrayal down the line.
makes sense.
And another piece of fidelity is keeping the focus squarely on the primary client. In complex situations, maybe family members are involved, or the client's competence is shaky, it can be easy to lose sight of whose needs and wishes should come first. The counselor's job is to prioritize that primary client, unless and until competency issues are formally sorted out.
Okay, so those are the 5 core principles. Now, the resource dives into some specific ethical issues that are especially relevant when working with people who have both HIV and substance use disorders. First up is the duty to treat. What's ethically unique about that here?
Right, the duty to treat. Ethically, it becomes especially critical when you're talking about populations that have historically been marginalized or faced discrimination getting care.
Like who?
Well, think about someone experiencing homelessness who also has chronic alcohol dependence and is living with HIV. A clinician working with them might hit major roadblocks trying to get them basic medical or dental care.
Why is that?
It might be hard to find doctors willing to treat someone with HIV, or maybe someone who's homeless and actively using substances. So in those cases, the substance abuse counselor might need to become an advocate.
Really step up.
Yeah, work within their community, raise awareness, push for better access to comprehensive care, and at the same time, ethically, the counselor and their agency have to make sure they're seen as welcoming and accessible to everyone without any discriminatory rules or practices that block care just because someone is perceived as different or has extra challenges.
And broader things can make this worse.
Yeah, sure. The resource notes that things like welfare reform, the rise of managed care, maybe limits in health insurance for vulnerable groups, all that can make access even harder. It demands more creativity, more persistence, more advocacy from clinicians.
And there's a caution in the resource, right? About ethical actions maybe leading to legal trouble.
That's a really critical point. The example given is a counselor feeling ethically bound to help a minor client who's using drugs, engaging in really high-risk behavior like exchanging sex for drugs, and is at high risk for HIV. The counselor might want to get them into treatment or get them HIV prevention info at a clinic. But if the minor's parents or guardians haven't consented to that medical treatment, the counselor and the agency could potentially face legal liability.
Wow. So you have to know the law, too.
Exactly. Acting ethically is vital, but you also have to be informed about the relevant laws in your area to avoid accidentally crossing legal lines.
Okay, another specific issue. Duty to warn. We usually think of that regarding, like, threats of violence. How does HIV status complicate this?
You're right. Duty to warn usually brings to mind direct threats to someone's specific or suspected child abuse. But with HIV and substance use, unique concerns pop up.
Such as?
Providers might learn that a client knows they're HIV positive but isn't taking precautions to prevent passing it on. The resource mentions news stories about people knowingly putting others at risk.
Yeah, I remember some of those.
So this raises a really tough ethical question. What does the clinician do with that knowledge? And again, legal liability is a factor. Counselors need to know their state laws. If a client with HIV isn't telling their partners, could the counselor be sued for knowing and not warning the partner?
That's heavy. What's the guidance?
Consult supervisors, know the agency policy inside out, and consider reporting to the public health department. They might have protocols. But each situation needs careful assessment based on its own facts and the relevant laws.
It sounds like a real clash between different ethical principles could happen here.
Absolutely. This is a perfect example of potential conflict. You've got beneficence wanting to protect society by stopping HIV spread. You've got fidelity, the promise to keep the client's information confidential. And non-maleficence, avoiding harm to the client by breaking their trust.
So which one wins?
Well, that's the dilemma. The resource makes you ask. Is reporting always the best way to do good long-term? Or is intensive counseling, aiming for lasting behavior change, ultimately more beneficial in preventing future harm? How much damage does disclosure do to the therapeutic trust? It really requires analyzing the immediate and long-term consequences, case by case.
Okay, moving on. End-of-life issues. With better HIV treatments, is this still a major ethical area?
It's true, treatments have drastically cut the AIDS death rate,
Wow.
but people are still living with a serious chronic illness, and sadly, mortality is still a possibility, especially when HIV is combined with the health problems from chronic substance use.
Right.
So clinicians might still work with clients facing end-of-life situations and all the ethical dilemmas that come with that. And it's worth noting the HIV community has a strong history of advocating for self-determination, fighting for access to experimental treatments, supporting organizations that help people who are dying. Because of this history, a client with HIV might decide to stop medical treatment, and they might not expect anyone to challenge that decision. It's rooted in that principle of autonomy.
And what if a client expresses a wish to end their own life? How does autonomy intersect with the clinician's duties then?
That's where it gets incredibly critical for the clinician to be direct. They must communicate clearly that they cannot keep confidentiality about a client's stated plan to harm themselves.
And when should that conversation happen?
Ideally, before it ever comes up as part of informed consent, discuss the limits of confidentiality right at the start, and if a client does express suicidal thoughts or plans, reiterate those limits immediately.
So the client knows the score.
Exactly. They need to understand the professional and agency rules, what the clinician has to do if such plans are shared. It empowers them to decide what they disclose. And again, providers absolutely need to know the laws in their specific area about this. But the resource also offers some reassurance. If you follow professional codes, agency standards, and document everything properly, your risk of legal trouble is much lower.
Okay, dual relationships is another challenge mentioned. What exactly is that, and why is it an ethical problem?
A dual relationship is when a provider has more than one kind of connection with a client. So besides the professional helping relationship, maybe there's also a social link, a business connection, maybe even a past or present sexual relationship.
Got it.
And the ethical problem is that blurring those boundaries can really mess with objectivity, compromise the therapy, and create conflicts of interest. It can be especially tough in small towns or tight-knit communities where paths cross more easily.
Can you give examples?
Sure, a clinician who's already friends with someone or used drugs with them in the past, or maybe a counselor managing someone who's also in their 12-step group or community organization.
So what's the rule?
Basically, avoid them whenever possible. If you have a prior or current social, business, or intimate tie to someone, you probably shouldn't become their therapist. Too much risk of conflicts, issues with disclosure, trust, power dynamic.
But what if it's unavoidable? Like very few providers in an area.
If it really can't be avoided, then clarity is everything. Clearly define the professional role boundaries, emphasize confidentiality strongly, and regularly check in with the client. How is this dual role feeling for you? Is it affecting treatment? You have to manage it very carefully.
Makes sense. Then there's scarce resources. Sadly, a common issue. How does this create ethical dilemmas specifically here?
Yeah, limited resources, treatment slots, support services mean providers sometimes face brutal choices when they just can't help everyone who needs it.
And the ethical question is,
How do you distribute those limited resources fairly, justly, without bias based on someone's background, culture, or which group they belong to?
so how should it be done?
The resource stresses needing objective, transparent allocation methods. Apply them consistently to everyone. And maybe have a review process so it's not just one person making the call.
Are there specific examples of tough choices?
Yeah. Funding for HIV services or substance abuse treatment can go up and down. Agencies might face situations where they have to, say, deny services to someone who's been through treatment multiple times without lasting recovery. The rationale might be that limited resources could be better used on someone seen as having a higher chance of success.
That sounds incredibly difficult.
It is. Similar dilemmas pop up with allocating expensive HIV combination therapies. Decisions might get influenced by how well a clinician thinks a client can manage the demanding medication schedule. It's fraught with potential bias.
Okay, finally, the last specific issue, confidentiality. We touched on it with fidelity, but it gets its own focus. Why is it so central?
It's described as kind of the connecting thread, the core issue linking all the principles. It truly is the foundation of trust in therapy.
Clients need to feel safe.
Absolutely. Safe knowing what they share is protected. But unfortunately, it's getting harder to maintain that. Managed care wants detailed reports for justification. More people might need access to treatment info.
And technology.
And computerized data systems, yeah. They bring potential risks for privacy breaches. Ethically and legally, providers have to be transparent. Tell clients what data goes to insurance, what might be shared with other agencies. Get that informed consent for any disclosure outside the direct therapy relationship. That's a legal requirement, like under IPOL here in the U.S.
So clients need to really understand what they're agreeing to.
Totally. What are the terms of treatment? What exactly are they consenting to disclose? But this doesn't mean providers lose all control. They should still use professional judgment. Be discreet in outside talks and documentation. Only report and record what's essential and directly relevant to the client's actual treatment and care.
Wow. Okay, this is all incredibly complex, very nuanced. To help professionals actually do this, the resource provides a practical, step-by-step model for making ethical decisions. Can you walk us through that?
Yeah, it's a really helpful framework for tackling these tricky situations systematically. Step 1 is crucial. Identify the clinical issues. Look at the whole client picture. What are their main clinical needs? How does this ethical problem relate to their core issues?
Okay, step 2.
Step 2, identify relevant legal issues. Know your state and local laws, federal regs that might apply. Get legal advice if you need it.
All right.
Step 3, identify system issues. What are your agency's specific policies and procedures that relate to this ethical question?
Got it. Number 4.
4 is identify cultural issues. Really think about the client's background, their values, beliefs. How might that shape their view of the situation or potential options?
Crucial. And 5.
5 is identify the ethical issues themselves. This often starts with that gut feeling, right? That sense that something's not quite ethically right. Then you need to examine your own feelings and reactions. Are any personal biases or countertransference clouding your judgment?
Self-awareness again.
Definitely. Then step 6, review which ethical principles are at stake. Is it mainly about justice, autonomy, beneficence, non-maleficence, fidelity, or maybe a conflict between principles?
Okay.
7, brainstorm possible options. List out all the potential ways you could handle this. Don't censor yet.
Then evaluate them.
Exactly. Step 8, review the pros and cons of each option. Think about the impact on everyone involved: client, clinician, agency, family, support system.
Good.
9, act. Based on that analysis, make a reasoned decision and implement it. Have a clear rationale for why you chose that path.
And it doesn't end there.
No. Step 10 is ongoing. Follow up and evaluate. Monitor how the decision affects the client. Did it resolve the ethical issue? Any unintended consequences? Keep checking.
That's a really thorough process. And the resource mentions other places professionals can get help with these tough calls,
Yes, consultation is highlighted as incredibly valuable.
talking to people.
Exactly. Formal consultation with your supervisor, always the first step. But also informal talks with trusted peers, experienced colleagues. When culture is involved, maybe consult experts from the client's background, always keeping confidentiality paramount, of course.
And legal help.
Legal consultation can be vital too. The resource suggests looking into pro bono services from bar associations, community legal aid, even the agency's own lawyer or board. They have a stake in decisions with legal implications.
It's just so clear that navigating this ethical landscape, substance abuse treatment for people with HIV/AIDS is incredibly multifaceted, demanding. It takes so much careful thought, grounding in principles, and just constant learning and reflection.
Absolutely. The principles, the decision-making frameworks we've discussed, they're vital guides for professionals facing these really, really challenging dilemmas. It's not just about knowing the theory, it's about that continuous self-reflection, open consultation, and an unwavering commitment to the client's well-being, their autonomy, their dignity.
So as you're listening, maybe take a moment and think about this.
Yeah.
Consider those times in your own life, maybe at work, maybe even personal relationships, where you faced a choice and the right path wasn't immediately obvious. The ethical principles we explored today, while focused on this very specific critical field, they actually offer a valuable way to think about ethical complexities in lots of different parts of our lives, something to mull over.